Hello and welcome to Season 2, Episode 76 of the Physician Assistant Exam Review Podcast. My name is Brian Wallace, and today we're going to be covering macrocytic anemias. All right, welcome to the show. This is the Physician Assistant Exam Review Podcast, where we cover tips and tricks and ideas for passing through PA school and passing the PANCE or the PANRE, depending on where you're at in your career. When I originally established this podcast, it was very much for people taking their PANRE, which was what I was doing. And I've told the story a few times. I was terrified of students, of people who were actively studying and in school, because my concern was they would know a lot more of the details of the medicine than I would, right? I'm in surgery. I don't practice medicine. So my medical skills compared to those people and medical detailed knowledge compared to those people in school currently studying each specific topic in depth and with lots of time, it probably doesn't match some of yours, but it's the overall approach in the way that I do things and the way that I teach things that I think is what you're going to walk away with. So as much as some of you certainly know a lot more medicine than I do, that's without a doubt. Probably the majority of you, if you stopped and thought about it. Like I said, I'm in surgery. I do a lot of sewing and stitching and cutting. I don't do a lot of medicine. But what I do and what I offer here is a way to break down the information, a way to break down the medicine into a format that is easily understood and a way that you can see things that maybe you didn't see before, or piece things together in ways that maybe you didn't piece them together before, to help your memory, to help you retain the information for longer periods of time, for your exams and for your patients, of course. That's our end goal, right? Is to get out and get a job and actually help people. So anyway, it's something that I was terrified of when I started this. So I want you to just understand that there's always something people are scared of. People have struggles with. You're currently struggling with being in PA school, right? Feeling like you're a beginner, feeling like you're just starting out. Everybody has that. You've got to get through it. You've got to fight your way through that. All the surgeons, everyone you work with who seemed so confident at one point were in your exact same shoes and had to just get through it. So keep that in the back of your head. I think it's extremely valuable to understand that nobody's a success on day one, right? It takes years and years of practice. So anyway, today we're going to be talking about macrocytic anemias. We're going to do a little bit shorter show today. Last one's a little longer side on anemia and the idea of anemia. And like I said, today we're going to be covering macrocytic anemias. So let's go ahead and get started with our priming questions right away. Yikes. All right, what is the test? Oops. That's for the end of the show. What is the test for measuring red blood cells? What's the test for measuring red blood cells? We're just going to review some of this stuff again, right? Priming questions. What is the test for measuring red blood cells? Define macrocytic anemia. Define macrocytic anemia. That's what we're going to be talking about today. Macrocytic anemia. Give two symptoms of anemia. Two symptoms of anemia. That should be pretty easy by now. Give two causes of macrocytic anemia. Give two causes of macrocytic anemia. All right, macrocytic anemia. Macrocytic anemia is produced strange, dysfunctional, large red blood cells. Macrocytes are greater than 100 on MCV, right? Microcytic was less than 80. Normal's between 80 and 100. We're talking about somewhere over 100 mean corpuscular volume. And mean corpuscular volume, don't let that get you too confused. I think some of these terms, they try to, some of this stuff is so easy, and then we put these big long names attached to it. So it's our average size of a red blood cell is all we're talking about there. So these are anemias which produce strange, dysfunctional, large red blood cells, or actually white blood cells also. This will result in some hemolysis and progress to splenic dysfunction as the spleen becomes overloaded. So you'll run into the term that we're about to get to, which is Howell-Jolly bodies. These are DNA remnants seen with a macrocytic anemia or a damaged spleen. What happens is that you'll get some small remnant of DNA inside of a red blood cell, and usually the spleen will clear that. But in these cases, the spleen's getting overwhelmed and it's not able to do that job as well. You'll find this in a B12 deficiency anemia, folate deficient anemia, something like a sickle cell. Again, we get that functional splenectomy, and celiac disease, or if someone does have their spleen removed. In all of these cases, the retic count will be low. This is because the body doesn't have enough supplies to produce the new cells. So in this section, we're pretty much going to be covering two macrocytic anemias. Sorry, I'm just looking ahead at something, making sure I have. All right, so we have a folic acid deficiency anemia. We have a B12 deficient anemia. Those are basically our two things we're going to be talking about today as far as our macrocytic anemias go. And as I've said before, this doesn't mean those are the only two things that cause a macrocytic anemia. Certainly not. We're going to talk next week, or in the next section, about hemolytic anemias and hemolysis and some bleeding issues that can lead to a macrocytic anemia. But for our purposes today, we're just going to deal with these two. So a B12 or a folate deficient anemia. A folic acid deficiency, there are causes there are going to be a decreased intake, likely secondary to alcohol abuse. That's going to be a major cause of folic acid deficiency, and in this case, a macrocytic anemia. You could also get decreased absorption of folic acid. One thing that may cause that is that there are medications that decrease the intake of folic acid, so methotrexate would be one of those. During pregnancy, folic acid levels tend to drop and we have to supplement it. And then something like a hemolytic anemia can reduce our folic acid. Clinical presentation, these patients have a sore or swollen tongue. They can have GI issues like diarrhea, pretty vague stuff there. They can have mouth and peptic ulcers. And they can have symptoms of anemia, which we're not going to review here again for the third or fourth time. One of the keys here is they have no neurologic findings. And the reason I mention that in particular is because B12, patients with the deficient B12 will have neurologic findings. And we'll get to that in a second. But when we cover two things like this, right, when we cover macrocytic anemias, and we basically have two causes we want to talk about today, which is folic acid deficiency and a B12 deficiency, one of the things you have to realize as you go through a topic like this is test questions are going to come in the form of differentiating these two things from each other. Let me say that again. Questions are going to come in the form of differentiating folic acid deficiency anemia from B12 deficiency anemia. And they're going to try to get you to choose between the two. It's just a very obvious way to write a test question. So as I'm going through a section like this, I'm looking for how do I differentiate these two? And again, people, I say this a lot now, people will say, oh, you're just teaching the test. No. This is also going to be in the clinic when you're treating a patient, right? Because the treatment is going to be different if they have a folic acid deficiency versus a B12 deficiency. So you're going to have to differentiate these two, and they look a lot alike. So it's how do we differentiate them? Well, B12 deficiency will have B12 deficiency will have those neurological findings, which we'll get to, but a folic acid deficiency will not. Labs and a folic acid deficiency, pretty standard stuff. This will be the same in both. The CBC is going to have a low H&H, an elevated mean corpuscular volume, remember we're over 100, and a low retic count because I don't have enough building blocks to create good cells. On a peripheral blood smear, we're going to find macroovalocytes. These are big oval red blood cells, and these are not seen under normal conditions. You can also see Howell-Jolly bodies, which we talked about earlier. These are a red blood cell that carries a small portion of DNA that's kind of left over that they didn't get rid of. And this cell type would normally be removed by the spleen, but the spleen has been overwhelmed. You also get hypersegmented neutrophils and some weird looking white blood cells. A folate level less than 150, and a B12 that's normal. Makes sense, right? Treatment. What is our treatment going to be for a folic acid deficiency? How about a folic acid supplement? Pretty straightforward stuff. Not a lot to memorize there. And then reversal of any causative agents or issues. A B12 deficiency is our next one, right? So causes here will be pernicious anemia is going to be our number one cause. This is the inability of the GI tract to absorb B12 due to a missing transport protein called intrinsic factor. So pernicious anemia means we're not absorbing B12 in the GI tract. Intrinsic factor is the transport protein that grabs onto the B12 and brings it into the body. This is the number one cause of a B12 deficiency, and it's most often caused by an autoimmune disease. Another place you can see this is with a complication of gastric surgery, because intrinsic factor is produced in the stomach. Now, B12 is absorbed in the terminal ileum, but intrinsic factor is produced in the stomach. So surgery at either location can cause a pernicious anemia. So a complication of gastric surgery is going to be you're not producing intrinsic factor, but a complication of bowel surgery is going to be you're not absorbing that B12 and intrinsic factor. Crohn's disease can also cause this problem because if you have an issue at the terminal ileum where B12 is normally absorbed, Crohn's disease can cause some issues there and keep it from being absorbed. And then a vegan diet can also lead to a B12 deficiency. If you have someone who's a vegan, or if you are, you have to really focus on maintaining your B12 level because animal products are our main source of B12. Meat, dairy, and poultry. There are other sources, but you have to pay attention to that. Clinical presentation. Here's where we get our neurological findings. So our stocking glove paresthesias. Again, this comes back to a funny term that I think drives students crazy and isn't a big deal. I don't know why I struggled with this one for a long time before I sort of snapped into it and understood it. A stocking glove paresthesia just means, think about someone putting a glove on their hand, and then as it comes up, so their paresthesia, their inability to feel things, starts at the fingertips and then comes up into the hand and then comes up into the wrist and then comes up into the elbow, as if you're putting on a glove, right? That's how this travels. And same thing with stockings. So think about putting on socks or stockings. It travels from the toes up into the foot and up into the leg. This is a description of how this paresthesia takes hold and starts to take effect. And it's the style that it occurs in. So the description makes absolute sense, but a lot of times we get hung up in the description and we can't get to the actual problem. So B12 has a stocking glove paresthesia. It's just meaning it starts out of the tips of the toes and the tips of the fingers and will climb towards the central body. These patients can also experience ataxia, which is poor coordination of movement. But think about this like the patient appears intoxicated, right? They're slurring their speech. They can't stand up. They have trouble moving with coordinated motion. So that's ataxia. Again, these are neurological issues in a B12 deficiency. They can lose their fine touch sensation. They eventually get to dementia, depression, and then obviously they'll have symptoms of anemia, which we're not going to go into here. So it's really focusing on those neurological issues. In our labs, again, we'll have a low H&H, an elevated MCV above 100, and a low retic count for the same reasons. Our peripheral blood smear is going to look pretty similar. It's going to have big oval red blood cells, those macrovallocytes, again, not seen under normal conditions. We could have those Howell-Jolly bodies with hypersegmented neutrophils. And here we can also have indirect bilirubin being elevated secondary to hemolysis. Serum B12 is usually very low. And you may find antibodies to gastric parietal cells and intrinsic factor itself. Treatment here, very obvious, as always, treat the underlying cause if possible. Again, if we've cut out parts of the stomach that creates intrinsic factor, we're not going to be able to fix that. We can use intramuscular B12, high doses of oral B12. Those high doses of oral B12 will allow some to pass through the small intestine even without intrinsic factor. You can give oral intrinsic factor, but if the patient has intrinsic factor antibodies, this obviously isn't going to work. One of the big keys here is you have to treat this very early because the neurological symptoms can be permanent. So ideally you treat this within the first 6 months. After 6 months, those neurologic issues may become permanent. All right, so that's where I wanted to get to as far as our anemia discussion for today. I'm going to go over one or two more things, but I just wanted to stop with B12 and folate deficiency anemias because the key here is going to be separating those two, right? Pulling those two apart and then pulling the rest of anemia apart as you work up a patient who has it, right? So the whole point of this is to try to figure out why a patient has anemia and then get down to smaller and smaller till you get to the diagnosis. So it's a kind of like a flow chart is a nice way to determine a diagnosis for anemia, right? So we can break it out from macrocytic and microcytic. We'll go through some others in the next show. And then you're going to break out microcytic based on the factors we discussed in the last show, and then macrocytic based on the factors we discussed in this show. So you can use MCV, you can use hypochromic or hyperchromic to help you with that. There's a lot of little clues in here to help you determine which way to go with anemias, and they're not too difficult if you can kind of follow the pathways. All right, so our next section, we're going to talk about our study tip for today. Our study tip for today is going to be really simple, and it's the idea of setting yourself up the night before. You want to be in a position to tackle whatever it is you're going to be working on, but you need to get that set the night before. You cannot wait until the morning to get yourself set up. So if I'm going to run, for example, I always have my shoes out and ready to go. And if I don't have my shoes out and ready to go the night before, do you know what happens? I don't run. It's the smallest thing in the world. But for whatever reason, I can't get over the hurdle to put my shoes and my shirt on and my shorts on if they haven't been set out the night before. If they're set out the night before, it is incredibly easy to get up and go. And I don't know what that huge difference is, where it takes 3 minutes, whether it's at night or in the morning. But if you do it the night before and get your brain tuned in and ready, then it seems incredibly easier to get that done. Where if you wait and try and do it in the morning, it's almost impossible. So I find the same thing with studying or trying to get work done. If I clear my desk the night before and I set up the coffee pot and I've got everything ready, so when I get up in the morning, I can get right to work, it's easy because all I have to do is get up and get to work. But if I get up in the morning and there are dishes in the sink and I can't find the coffee and my desk is a mess, so maybe I should clean it, and there are all these excuses and other reasons not to do things, it's really, really hard. So it's a lot of what I talk a lot about is getting out of the moment. So it's in the moment, it's easy to make a bad choice because you don't feel like being there. You don't want to do whatever it is that you set up and you decide to do. But when you decide outside of the moment, before there's a fight with your brain about getting it done, it's so much easier to push yourself in the right direction. So look for those times when you can do that, whether it's the night before you want to run, the night before you want to study, the night before you want to get something done early in the morning, or if you're someone who wants to get some work done right when you get home, leave yourself set up for that in the same way. So in the morning, set out your shoes so you're ready to go for your run. Clear your desk in the morning so when you get home from school or work or whatever, you're ready to study. But you set yourself up before, not at the time you want to do it. It'll make a big, big difference. One thing I want to move on to today is some focal points for discussion purposes. So we're going to move into that right now. So one of the things we talked about today were macroovalocytes, those big, funny-looking oval red blood cells. You will generally only see these with folic acid or B12 deficiencies, at least as far as we're concerned here. I would focus 100% on those being a folic acid or B12 deficiency issue, anemia, if you see in a test question macroovalocytes. Howell Jolly bodies should make you think of B12 or folate deficiency anemia. They may also be seen in sickle cell, which we haven't gotten to yet, in celiac disease, because you get that those issues with the spleen. But those are 4 places where you're going to find the Howell Jolly bodies. And then if you see stocking glove paresthesias, there's basically 2 places where we see that. One is going to be a B12 deficiency, and the other is going to be diabetic neuropathy. You can get in other places. Again, don't hold me down to just pure black and white of everything that I say. But you can, the 2 main places you're going to see those on test questions is going to be a B12 deficiency and a diabetic neuropathy. All right, let's answer our priming questions. What is the test for measuring red blood cell size? Mean corpuscular volume, and define macrocytic anemia. We did that a few times today. It's over 100. Give 2 symptoms of anemia. You should be really good at this by now. Fatigue, pallor, brittle nails, dizziness, tachycardia, and on and on and on and on. Give 2 causes of macrocytic anemia. We only talked about 2 today. Give 2 causes of macrocytic anemia. A B12 deficiency and a folate deficiency would work. Yeah, and that's it. Those are our priming questions for today. Excellent work, folks. I'm so glad to have you along today. This has just been a ton of fun. If you are interested in finding out more or finding the old podcasts. So this is kind of fun. I just got this done last week. I spent 2 days working solely on this. I uploaded all of the old podcasts into the Physician Assistant Exam Review app. So it's super cool to see. It's really easy to work with. You can fast forward, you can rewind, you can speed up the playback, you can slow down the playback, you can take notes right in the app. And it has everything downloaded right to your phone. You can check off which ones you've completed, which ones you haven't. It's all right on your phone. It's super easy. And you can find out more about that at www.physicianassistantexamreview.com/podcast, PODCAST. We'll get you all the information there is on that. So if you're interested in those back issues, which are not in the feed, then you can get those all on the app. And actually getting all the episodes in the app is a nice way to do it. It's nice and clean functionality. I really like how it's come together. So if you want to look more into that, www.physicianassistantexamreview.com/podcast. Take care. I'll see you next time.